everybody, and welcome to Module 8. This video lecture will be about several cognitive modalities, including cognitive behavioral theory and therapy, contextual therapy, cognitive processing, and also dialectical behavioral therapy. This week we're going to go sort of beyond all the basic approaches we've been covering so far to working with survivors and turn towards looking at some of the specific modalities and models of care. We'll overview cognitive behavioral theory, which may be somewhat of a review from you from previous classes. We'll talk a little bit about cognitive processing. We'll talk a little bit about contextual therapy, and we'll talk a little bit about dialectical behavioral therapy as well. So what is cognitive behavioral theory? So overall, this is a theoretical and practice approach that maintains that a person's thinking or cognitions are the prime determinant, although not the only one, of emotional and behavioral responses. So it's not a single approach to therapy, but rather a group of therapies. And it represents a blending of cognitive and behavioral theories that have been passed down to us historically. So it's not about just positive thinking. It's actually much more involved than that. A key principle of CBT is that cognitions are the prime determinant of our human emotions and behaviors, although not the only one. And that these idiosyncratic processes, meaning, appraisals, assumptions, judgments, conclusions, etc., that attach themselves to events, rather than the event itself, determine how we react to those events and life situations. In other words, it's the meaning that we attach to these situations rather than the situation itself that contributes to one's emotional and behavioral responses to life's events. Cognitive behavioral therapy is an umbrella term that encompasses various approaches to the practice of psychotherapy. All of these approaches are linked by the predominance that they give to cognitions as the prime determinant of behavior. Some of the better-known variations of CBT are cognitive therapy, rational emotive behavior therapy, dialectical behavioral therapy, self-inoculation or self-instructional therapy, and many others, including multimodal therapy, reality therapy, and acceptance and commitment therapy. Some of the hypothetical assumptions that underscore most CBT approaches are that cognitive processes and content are accessible and can be known, that our thinking or our cognitions mediate how we respond to our environment, and that these cognitions can be intentionally identified, targeted, and modified to bring about symptom relief and improve functioning and adaptability. And you can read more about this if you read the work of Dobson. And I also would like to credit Antonio Gonzalez Prendes at Wayne State University, who originated some of these slides. He's quite a CBT scholar, and I learned a lot from him. So there are 10 key principles of cognitive therapy as laid out by Beck, one of the prominent researchers in this area. Some of these principles are that we conceptualize problems in cognitive terms, we develop a sound therapeutic alliance, we elicit active collaboration and participation from clients, that we be problem-focused and goal-oriented, that we focus on the present here and now. So what are you thinking and feeling right now? We'll focus on education and acquisition of coping skills. A feature of much of CBT is that it's quite time limited, which is also why insurance companies tend to pay for it. And it is use typically a structured and very active approach from the therapist. And what it does is help clients to learn to identify, evaluate, and respond more functionally to their irrational thoughts and beliefs. And different approaches use a variety of strategies to change thoughts, moods, and behaviors. So it's important, since there are so many, to provide a really clear rationale for the treatment strategy, whichever particular one it is that you're going to use. The philosophical underpinnings of CBT have been influenced from various sources, from various disciplines, including various philosophical and psychological schools of thought, psychodynamic and psychoanalytical therapy, logotherapy, or existential therapy of Viktor Frankl, for instance, neuroscience, linguistics, among others. Among the oldest influence are the Stoic philosophers, with their emphasis on rationality and search for evidence when dealing with what the world has to offer. One of the main proponents of Stoicism was the Roman philosopher Epictetus, who discussed how thinking affects one's emotional and behavioral responses. Modern-day cognitive behavioral therapy has also been influenced by Eastern philosophies. Concepts such as radical acceptance, tolerance of ambiguity, and mindfulness are among others, are concepts found in the teachings of Eastern philosophies. So we have cognitive, but we also have behavioral. And behaviorism, some of the behavioral theories propose that all behavior is learned as a result of conditioning. And so that the focus of investigation when we're looking at this should be on observable and measurable behaviors. So it's an empirical investigation. It's not what you're telling me or what you're thinking of. What's your behavior? And we know that human behavior can be controlled by manipulating environmental conditions. Some of the origins of specifically behavioral theories, some of the early influences include Ivan Pavlov's experiment on animal conditioning in the early 1900s, various learning theories, classical conditioning and classical conditioning theory. John Watson was one of the main guys involved with that. He was very influenced by Pavlov's experiments and classical conditioning theory. And you may have heard of the case of little Albert, where they basically conditioned a fear of rats into this poor little kid. B.F. Skinner took off on this with his operant conditioning theory. Albert Bandura took off from that with social learning theory, which encompasses classical and operant conditioning and observational learning. Then you've got Maurer, who brought us the two-factor learning theory, and Wolpe, who brought us the reciprocal inhibition theory. So there is quite a lineage there. So if you remember about classical or Pavlovian conditioning, it focuses on antecedents of behavior as the prime determinant of behavior. So basically it's about learning through association. So you have an unconditioned stimulus, which is the food, right? And then you have an unconditioned response, which is salivating in response to that food. And then you introduce a neutral stimulus, which is a bell, and that combined with the unconditioned stimulus of the food, that you still have that unconditioned response, right? But over time, by associating those two, we're going to have the conditioned stimulus of the bell, and that will lead to the conditioned response of the salivation, even though we don't have the stimulus of the food present anymore. Just to remind you how that works. So in terms of how this has come down and filtered down and is applied in therapy, I think today we could see counter-conditioning or systematic desensitization. It's also referred to as reciprocal inhibition. This is the idea of eliminating anxiety through relaxation. I think you could argue that that's part of the lineage. And certainly exposure therapy. That's often used post-trauma, and that's the graduated exposure to a fear stimulus, to keep exposing someone to what they fear until it takes the sting out of it. Imaginal exposure was first used to treat PTSD in combat veterans. Veterans with PTSD treated with imaginal exposure, then termed imaginal flooding, improved relative to waitlist controls and standard treatment respectively, although the magnitude of their improvement was moderate. But it has been used time and again. There have been some concerns voiced about exposure therapies, that it's too much for some people, that the flooding is without all those adequate phased treatment pieces is not good for people. But despite this accumulating efficacy for the evidence for the efficacy of prolonged exposure, these concerns do persist. However, recent studies have found that both cognitive therapy and imaginal exposure are equally effective in interventions for chronic PTSD. In their discussion, however, they asserted that a significantly greater number of patients receiving imaginal exposure worsened over treatment. However, this effect disappeared by follow-up. So you can read more about this, but one of the ideas around this is, are we working in the window of tolerance, right, that we've discussed before? So we have to make sure that we are really meeting that client where they're at and not, and keeping them in their window of tolerance for doing that kind of work. So that brings us back to operant conditioning, the main proponent being B.F. Skinner. And this is where you have operant behaviors seem to occur at random and draw a response from the surrounding environment that in turn reinforces or weakens the behavior. So here we're focusing on the consequences of behavior as the prime determinant of behavior. So this is where we have our reinforcers, our positive and negative reinforcers, and punishers as sustaining behaviors. So a positive reinforcer would be a pleasant reward or condition, money, a gold star, whatever it is. A negative reinforcer would be the removal of a noxious condition. You have variable schedule of reinforcement is a feature of this, approximation of the behavior, and then extinction, which is about removing the behavior. So applications to this in the sort of more modern therapeutic world would be contingency management or token economy. So there are programs where you actually pay people to stop certain behaviors, whether it be smoking or substance using, right? Or give them some other kind of a reward system to get them to stop smoking. Another CBT big hitter is social learning, and this was brought to us by Albert Bandura and others. And this is based on observational or vicarious learning, so this focuses on the reciprocal interaction and the social context between the individual and the environment, right? So the stimulus response model of operant conditioning is applicable to humans, and the SOR model is like an update to the same. It introduces the idea that the organism may choose to respond to the same stimulus in different ways depending upon their state of mind. An example would be a child who loves playing video games, generally responding by playing. That's response number one. When he is presented the stimulus of a video game in front of him. If the child plays the game and then the mother gets mad at him, then this response of the mother also becomes a feedback for the child. The child now associates fear with playing the video game in front of him. In the future, whenever the mother is present, due to the mental state of fear, the same child will respond to video games by avoiding them, potentially. Although my experience with my kids is, you have to do a whole lot more than that to get them to avoid video games. But so some of the key terms in behavior therapy, we talk about antecedents to the behavior, we talk about consequences and reinforcements, what positively reinforced that behavior, what negatively reinforced that behavior, was there punishment involved. We talk about a variable reinforcement schedule of the behavior, the extension of the behavior over time, generalization, um, uh, uh, overgeneralization, and that's a cognitive distortion. We come to a general conclusion based on a single incident or a single piece of evidence. So if something bad happens only once, we might expect it to happen over and over again. So a person may see a single unpleasant event as part of a never-ending pattern of defeat. So just to put this in a nutshell, it's the ABC model. That's right. You have your antecedents or triggers, and then the behaviors that's related to the trigger, and then the consequences of that trigger. Are there rewards from that behavior? Are there punishments related to that behavior? Or are there some secondary gains related to that behavior? This is just another way to depict this. An antecedent factor which preceded a behavior might be a nightmare or flashback of a sexual abuse memory, right? And so that might lead to a behavior like self-harming, cutting. And what are the consequences of that behavior? Well, in the short term, it might help that person feel grounded. It might reduce their panicky, overwhelmed feelings. In the long term, it might lead to shame about their inability to cope in a more healthy way. What about the antecedent behavior of sort of the daily tasks of leaving the home? That might result in the behavior of avoiding social activity, right? So maybe not taking the kids to school. And the consequence for that might be feeling less anxious when you avoid going out, right? So you can avoid that anticipatory anxiety by not even committing to engage in that activity, right? An antecedent factor might be time home alone during the day, using that to think about life. But a behavior that could result is rumination about fault and blame for the traumatic events, which in the short-term consequence could be feeling semi-productive at the time, like I might solve it, but the long-term might feel I'll never solve it. I feel depressed and hopeless. Another sort of way to look at this, antecedents, behavior, and consequences, would be the antecedents or triggers could be affective, they could be somatic, they could be behavioral, cognitive, contextual, or relational. Any of those domains could trigger us. Then the behavior, when we are looking at it in this therapeutic context and trying to help people, we want to look at specific behaviors that are observable and measurable. So we want to ask questions about what's the frequency of that behavior, what's the strength or intensity of that behavior, or feeling. How long does it last? How intense? Where does it typically happen? With whom? What's the context, right? And then the consequences or secondary gain for some of these behaviors in all those same domains that the antecedents were in. That would be sort of part of our behavioral case formulation. Just to put another example on this, an antecedent stimuli might be a coworker made a suggestion to Louise about what she could do to increase her sales. Louise felt criticized and belittled. She felt anxious about losing her sale. She imagined her husband being angry at her and her family disappointed. Her response or behavior: Louise shouted insults at the coworker, clenched her fist, threatened the coworker, saying, "You have a lot of nerve telling me what to do. If you say anything else, I will punch you in the mouth." She felt anxious and angry. So what were the consequences? The negative consequence was the boss reprimanded Louise for outbursts and shouts. She was informed that further outbursts could result in job loss. A positive consequence, though, was that her coworkers leave her alone. So she's less likely to feel criticized by them and maybe less likely to feel anxious because she's basically not having contact with them. And then what was the strength of her response? That's also an important thing. Like if this is just a one-off, that's one thing. But Louise is having these outbursts about 4 or 5 times a month. The mean duration of an outburst is about 5 minutes. Intensity of her emotions and behavior is about 9 out of 10 points on the subjective units of distress. I don't think we've talked about that yet, but I'm hoping that you've come across that in other classes. That's just that where you ask someone on a scale of 1 to 10, or 0 to 10, with 0 being you're not having any distress at all, feeling any distress at all, and 10 being that you're feeling the most stress possible. Where do you fall right now? And that's just a good way of checking in with your client when you're in session with them. And we find that there's about a 5-minute interval between the stimulus and the response. So that's important information to have when we're assessing what's going on with a client. You look at Albert Ellis's model. He's expanded that sort of simple ABC to the ABCDE model, which would be, again, with the activating event or antecedent event, which he's calling the activating event. My manager criticized my project and told me I had to do it again. And then you have your beliefs about that event. That's selfish, ungrateful SOB. After all I've done for him, this is how he pays me back. He has it out for me. Then you have the consequences. Being very angry, like 80 out of 100 on the scale, and defensive, swearing at the manager, calling him a name, slamming the door, walking out of the office. Then you have this new category of D, the disputation of beliefs. He tends to be demanding with all, not just me. He is the manager. He has to ensure that the project is done to his liking. I'll ask for details. So that's where you're encouraging the client to say, is there another explanation for the manager's behavior here that you hadn't considered? Can we look at an alternate explanation? And then that might lead to new emotions and behaviors. So feeling disappointed that his project was not accepted instead of just completely angry. And then perhaps might be more open to talk about it calmly and rationally and not in a defensive manner going forward. As you can see, it gets a little complicated when you're looking at the cognitive case conceptualization. You have to take into account all the relevant background data of your client. What are their schemas, their thoughts, their core beliefs about themselves and the world and what's going on, some of their core relationships. Then you have to look at some of their intermediate beliefs and some of the conditional assumptions. If I do this, then this is going to happen. And what rules they have about their beliefs. I should always do this, or I must do this, or this is going to happen. Those kinds of things. And then what are the compensatory strategies that your client has developed to deal with this whole system of belief that they have, right? And then you have to drill down to, well, what's the specific situation that we want to talk about? And then when you're talking about that specific situation, you can get at what are the automatic thoughts that pop up when dealing with that situation, and what's the meaning of that automatic thought, right? And what's the emotional response that comes with that automatic thought? Is it depression, anxiety, anger? And what's the behavioral response? Do you isolate yourself? Is this when you're drug seeking? Do you become aggressive, right? So that's just kind of a broad way of looking at that. And would be an example of that. So here's a person with a history of abuse and neglect. They're often put down and belittled by their parents and significant adults. They were ridiculed by other children. So their cognitive schemas are, I'm unlikable, I'm defective, I'm not good enough, others can't be trusted, the world is a harsh place, right? So those lead to some intermediate beliefs. If I please others at all time, they will like me, right? So maybe I can do something to change this overall, these core schemas here. Or I should not disagree with others, right? Maybe those would be ameliorating effects of that stuff up above. So as a result, the behavior is I'm always going to say yes. I'm going to take on too many tasks. I'm going to go out of my way to please others, even when it's burdensome. And that's going to result in other behaviors like working every weekend. Even though I have a major exam on Monday, if my friend asked me, and then my friend asked me for help moving on Sunday, I'm going to immediately, my automatic thought is going to be, if I say no, they're not going to like me. They'll be angry at me. Even though I have this mountain of work, right? But if I say no to them helping with moving, they're not going to like me. And then my emotional response is really a lot of anxiety and fear about them not liking me, and maybe resenting me, or me resenting them asking me when they know, maybe they know or maybe they don't know that I'm so busy. And then a behavioral response, a somatic response really could be being really on edge, being worrisome, having headaches, palpitations. This would just be one example of how that might play out. So, shifting to CBT in general, specifically for PTSD, we have the prolonged exposure, what I was referring to as an imaginal exposure. Now it's usually called PE, or prolonged exposure. Cognitive processing therapy, CPT, eye movement desensitization and reprocessing, EMDR. We'll be getting into that in a future module. Stress inoculation therapy, STARE, MPE, and seeking safety. I'm not going to go into the last three here, but I wanted you to know that for sort of quote-unquote simple PTSD, those are definitely all in use. Overall, when we are applying CBT principles to complex PTSD, we need to really specifically look at the clinical applications of this. We want to make sure that we're addressing emotion regulation and dissociation, right? Because that's an added feature of the dissociative subtype of PTSD, or what we're referring to sort of more broadly as complex PTSD. We want to look at insecure and disorganized attachment and relationship problems. Again, that might be a feature of somebody with complex PTSD. And we want to address somatic symptoms, so what's happening in the person's body, too, in relation to their trauma and their PTSD symptomatology. So in terms of phases of CBT treatments, in our Courtois and Ford book, they talk about basically two main phases. The first one being the safety and stabilization, which we've talked about before. And during that phase of safety and stabilization, you're also working on the emotion regulation and the interpersonal self-regulation. And then phase two would be the emotional processing of the traumatic memories themselves. So there is a case example in your book that walks you through these phases, and I really encourage you to refer back to that. And although our book doesn't include the third phase of reintegration as a phase in that chapter, we can presume that this is happening sort of in tandem with phase two when you read about the trauma narrative and how it was analyzed and how the implications of that were discussed. I think that would be our sort of classic reintegration, if you will. I want to talk a little bit about some work by Rizik and others on cognitive processing. And you can find out more about this on the National Center for PTSD website if you're interested. And cognitive processing therapy, or CPT, is a CBT type therapy for PTSD and related conditions. It typically consists of 12 50-minute therapy sessions and has been found to be effective in treating PTSD across a variety of populations at this point, including for combat veterans, sexual assault victims, and refugees. The theory behind CPT construes PTSD as a disorder of non-recovery. Specifically, symptoms are attributed to an inhibition or stalling out in the natural process of recovery, which prevents individuals from completely working through troublesome trauma-related thoughts. CPT uses trauma-specific cognitive techniques to help clients move past these stuck points and progress toward recovery. Importantly, this therapy can be conducted with or without a written trauma account and can be used in individual or group formats. I wanted to say a little bit about contextual therapy. This is a therapy very specifically for survivors of prolonged child abuse, or what we call PCA sometimes. As Stephen Gold says in our textbook, A prime example of complex PTSD that prolonged child abuse is a prime example of complex PTSD and the main reason for developing contextual therapy. It was developed to address the notion that many of the psychological difficulties, including borderline personality disorder, somatization disorder, multiple personality disorder, which we now refer to as dissociative identity disorder, are often related to prolonged child abuse, but are not recognized per se as being trauma-related disorders. Because a lot of the symptoms people so affected did not fit the diagnostic formulations, people, especially women, were seen as exaggerating or kind of making things up. So what researchers who developed this found was that simply applying PTSD treatments that worked for those with single traumas to those who had prolonged child abuse did not work well. And in fact, sometimes made things worse for individuals. In the absence of existing treatments, what therapists at the Trauma Resolution Integration Program in Fort Lauderdale did was to turn to their clients and allow clients to guide their staff to what was important to them. Instead of spending a lot of time processing traumatic narratives, what the clients described was what Gold called the unremitting bleak tenor of their everyday lives growing up. In other words, the context of their lives. This is what was really hard for people, was dealing with the context of their lives. I really like this because it's kind of how I think of childhood sexual abuse and physical abuse and everything else, is that I feel like a childhood sexual abuse or a child who's being physically abused in some way, that those are like the poisonous mushrooms kind of rising out of this miasma of a really bad context, right? So, and that includes, you know, really poor family environment, really poor family functioning, it includes emotional abuse, it includes other long-term problems, it includes maybe some deficits in development and knowledge on the part of the child growing up in such an environment. And so this idea really fits with my take on how this all works, because it really addresses the whole context of people's lives, right? People who grow up with chronic abuse like that can really experience critical gaps in their learning and development that need real remediation. So if you recall, Judith Herman outlines 3 basic stages to trauma recovery. The first is safety, which is generally where people enter treatment and is actually a stage that takes a long time to establish. And we're just focusing on safety, 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 and we may get stuck in safety a whole long time. The second stage is remembrance and mourning, where we assess what we've lost, basically, by dealing with all this trauma in our lives. And the third stage, reconnection, is all about creating a new future and moving forward. A difference with contextual therapy is that instead of the reconnection, you may have to help your client actually develop a connection in the first place. For that might have been something that was missing in that sort of miasma, that horrible environment that they were growing up in. So they may not actually have any good models for what a healthy relationship looks like. So nothing really to reconnect to. So that's a particular challenge for working with people who've had multiple sustained abuse like that. So there are 3 major areas of contextual therapy. There's the interpersonal, the practical, and the conceptual. So teaching clients how to work in a cooperative interpersonal relationship. Teaching what rapport is. Practical concerns are definitely high priority, like teaching a client how to self-soothing behaviors. And then you have to also deal with the real situation of dissociative tendencies. And so somebody that's using dissociation as a coping mechanism obviously is not coping well with when they're aroused, right? So we have to teach ways to reduce arousal and increase capacity to stay focused when otherwise there's little else we're going to be able to do in terms of cognitive processing and learning, right? All the stuff that we've been learning about the brain, if if you're in the trauma or you're dissociated from the trauma, you're not processing, your executive functioning is impaired, and you're not going to really be taking in what's happening in the therapy room, right? So the conceptual area of contextual therapy is all about guiding the client through the process of thinking something through to a conclusion. For this, Gold and others employ a standard CPT procedure of Socratic reasoning. But unlike Socrates, the therapist must not assume that they know the right answer to the issue being discussed. Often it's best to let the client lead this and come to their own conclusions. Other times it might make sense to help guide them to a positive answer that makes sense. I would encourage you to look at the transcript of a session of doing this type of therapy in Chapter 11 of our textbook. I want to move to talking about dialectical behavioral therapy. DBT is a cognitive behavioral treatment program developed for suicidal clients who met criteria for borderline personality disorder. It targets specifically suicidal behavior, behaviors that interfere with treatment delivery, and other dangerous, severe, or destabilizing behaviors. DBT addresses 5 functions. Increasing behavioral capacities, improving motivation for skillful behavior through contingency management and reduction of interfering emotions and cognitions, assuring generalization of any gains realized to the natural environment, structuring the treatment environment so that it reinforces functional rather than dysfunctional behaviors, and enhancing therapist capabilities and motivation to treat patients effectively. These functions are divided generally among the following 4 modes of service delivery. One is weekly individual psychotherapy, typically an hour a week. Then you have a group skills training, which is like 2.5 hours a week. And then you have phone consultation as needed within limits of the therapist's predefined limits. And weekly therapist consultation team meetings. And this is the part that's going to enhance therapist motivation skills and provide therapy for the therapist, the supervision that would be so critical in working in this way. So, since we brought up borderline personality disorder, I thought I should do a brief overview of personality disorders. So what are personality disorders? They've been defined as overly rigid patterns of maladaptive behavioral responses, or seen as extreme variations of underlying personality traits. Persistent disorders are definitely resistant to change. The DSM-5 defines a personality disorder as this: an enduring pattern of inner experience and behavior that deviates markedly from the expectations of an individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. It's important to know that there's a difference between having a personality trait and having a personality disorder. Personality traits do not reach the point of causing significant impairment or distress. That's a key difference. In making any diagnosis, there needs to be consideration to the level of impairment in the daily life or subjective distress for the individual. Borderline personality disorder is defined as a pervasive pattern of instability of interpersonal relationships, self-image and affects, and marked impulsivity beginning by early adulthood and present in a variety of contexts as indicated by 5 or more of the following. Frantic efforts to avoid real or imagined abandonment. A pattern of unstable and intense interpersonal relationships characterized by alternating extreme alternating between extremes of idealization and devaluation. So people are on the pedestal, they're knocked off the pedestal. Identity disturbance, markedly and persistently unstable self-image or sense of self, and impulsivity in at least 2 areas that are potentially self-damaging. Recurrent suicidal behavior, gestures or threats or self-mutilating behavior, affective instability due to a marked reactivity of mood, chronic feelings of emptiness, inappropriate intense anger or difficulty controlling anger, transient stress-related paranoid ideation, or severe dissociative symptoms. So you can see that there's a lot of crossover with what we've been talking about in terms of complex PTSD or just the dissociative subtype, right? The way a person might present clinically is with the instability and intensity of interpersonal relationships. These may be displayed by a premature disclosure and belief in a more intimate relationship than shared, right? So somebody that comes in and you're the best therapist they've ever met and they're going to tell you all the intimate details right away. They may demonstrate shifts in both his or her self-appraisal and that of others. For instance, idealizing, then quickly villainizing a person. That's you're on the pedestal, you're off the pedestal. These usually manifest themselves in the therapeutic relationship along with an intense fear of abandonment. And again, you can see the crossover with problems with attachment and living in that sort of miasma, right? The clinical picture is characterized by emotional dysregulation. Self-injurious behavior is often but not always present, but you should note that 8 to 10% of people diagnosed with borderline personality disorder complete suicide. Okay? 69 to 80% have some kind of suicidal behavior. There are other impulsive behaviors as well, gambling, engaging in unsafe sex, overall risky behaviors that may result in some kind of damage. 40% of the highest users of inpatient psychiatric services receive a diagnosis of BPD. Patients with BPD use more services than those with major depression and other personality disorders. And among those patients with BPD seen for treatment, 72% have had at least one psychiatric hospitalization and 97% have received outpatient treatment from a mean of over six previous therapists. But despite this high use pattern, patients with BPD have high rates of treatment failure. There is a tendency to self-sabotage, like dropping out of your educational program just short of graduation, engaging in self-injury after months of remission, and after hearing that perhaps that your therapy is coming to a close. Another hallmark quality to this disorder is the emotional response it can elicit from the treating therapist of frustration and sometimes even burnout. So it's really important to have really good tools for working with someone for who this is an issue. This is just a case example. The patient is 28-year-old single female who works as a manager for city government. She's struggled with an unstable self-image, chronic feelings of emptiness, and difficulties maintaining close romantic relationships for all of her adult life. But she has a few close female friends and is considered a good worker. She's extremely self-critical and attempts to boost her self-esteem by seeking the approval of others. She has been told that she is needy and often seems desperate, which leads to some difficulties in maintaining romantic and other close relationships, although she often does not understand what she does that makes this impression. She experiences fluctuating strong emotions such as panic, fear, depression, and anger in response to interpersonal disappointments. She has made several suicidal gestures by cutting herself in the past couple of years when stressed by the ending of a relationship. So that's just a clinical picture of someone that meets the BPD diagnosis perhaps, but yeah, I think you can also see the crossover there in terms of maybe some bit of dissociation, the somatization, chronic PTSD, I think there is a lot of crossover. But we need to be aware of this diagnosis when we're talking about working with survivors of childhood sexual abuse or sexual abuse in general, because there is going to be a lot of crossover. So just to summarize, as you can see, there are many CBT treatments for PTSD and chronic PTSD. They have a strong and long lineage from both the cognitive and the behavioral fields that bring them to the here and now. There's a lot of commonalities between the various CBT treatments, but there's some differences as well. And so it's not any one treatment is going to work for any given individual, right? Or for any given therapist, right? You might be more comfortable working in one manner than another. So it's really good to have several tools in your toolkit, and I hope this can help you to discern, some of the directions that you might want to be heading.